Hello, and welcome to Sleepy Histories. Many of us are familiar with the romanticized myth of the so-called almond-shaped eye, a feature often described in literature as a mysterious, exotic trait defined by a delicate singular sweep of the lid. We often imagine it as a poetic hallmark of heritage, a purely aesthetic grace note of the East. But the real life of this anatomical feature is far more rugged and complex than any poem suggests. It is not a decorative choice, but a battle-hardened legacy of survival. Tonight, we will leave the legends behind and see what it was really like. We will explore the brutal, freezing winds of the late Pleistocene that sculpted the face, the fascinating biomechanics of the epicanthic fold that shielded the vision of our ancestors, and the modern medical science that now defines this gaze. So please like and subscribe to join our journey through time, and share your location and local time in the comments below. The landscape is a vast, monochromatic expanse of the late Pleistocene, where the horizon is indistinguishable from the sky. You are positioned within a terrain defined by absolute thermal hostility, a world sculpted by the relentless movement of glacial sheets. Here, the primary architectural force is not stone or wood, but the wind. It carries with it an abrasive payload of crystalline ice, moving at velocities that strip heat from exposed skin within seconds. You hear the biting whistle of a glacial wind against the face, a high-frequency drone that signals the onset of a whiteout. In this environment, survival is not merely a matter of strategy, but of biological refinement. To witness the inhabitants of this era is to observe a species in a state of constant physiological negotiation with the elements. At the center of this negotiation is the eye, the most sensitive organ to thermal and radiant trauma. You observe a specific morphological feature that serves as a primary defense mechanism, the tymenthic fold. This is a fold of skin covering the inner corner of the eye, reducing or eliminating the appearance of an eyelid crease. From a technical standpoint, this structure alters the ocular profile, creating a streamlined surface that minimizes the area exposed to the external environment. While modern science acknowledges that the precise evolutionary function and origin of the epicanthic fold are not fully understood, the prevailing hypothesis suggests the fold provides protection from cold, wind, and snow blindness. You are looking at a living filter, a structure designed to mitigate the dangers of a high-latitude existence. The mechanics of this shield are grounded in the physics of light and temperature. In this prehistoric Arctic setting, the sun does not merely shine from above. It reflects off the permanent snowpack with a luminance that can reach up to 10,000 nits. This causes photokeratitis, or time snow blindness, a painful condition where the cornea is essentially sunburned by reflected ultraviolet rays. The epicanthic fold acts as a natural visor. By narrowing the palpebral fissure, the opening between the eyelids, the fold restricts the amount of peripheral light entering the eye. This structural narrowing provides an essential layer of protection from the desiccating effects of high-velocity winds. When you turn your head into the gale, the presence of this tissue ensures that the sensitive lacrimal apparatus, the system responsible for tear production, remains shielded from freezing. This adaptation is not universal, yet its prevalence in specific populations is statistically significant. Data suggests that epicanthic folds are most commonly found in East Asians and Southeast Asians, with a prevalence of up to 90%. It appears as a localized solution to a global challenge: how to maintain visual acuity in conditions that threaten to degrade it. As you track the movements of a prehistoric hunting party through the tundra, you see the utility of this anatomy in practice. While a wider, more exposed eye would suffer from constant tearing and the risk of corneal freezing, the shielded eye remains clear and focused. The moisture of the eye is retained, the warmth is concentrated. There is no wasted energy in the squint. The biology has already performed the compression for you. The tactile reality of this era is one of extreme friction. The air is so cold that it feels metallic, leaving a sharp, copper-like taste in the back of your throat. Every breath is a calculated risk to the lungs, just as every glance is a risk to the retina. The epicanthic fold represents a triumph of soft tissue engineering over these environmental stresses. It is a testament to the way the human form can be reshaped by the climate it inhabits. This fold is not merely a characteristic of beauty or heritage. In the context of the Pleistocene, it is a survival tool as vital as a lithic blade or a fur wrap. It is the result of thousands of generations interacting with the harsh reflective surfaces of the northern latitudes. The fold is a permanent record of the wind's force and the sun's glare, written into the very skin of the face. Standing in this frozen silence, you realize that the human face is a map of past survival. The epicanthic fold is a physical barrier between the vulnerability of the eye and the violence of the Arctic atmosphere. It works in tandem with subcutaneous fat to ensure that the organism remains functional in temperatures that would otherwise be lethal. As the sun begins to set over the jagged horizon, the light shifts into a spectrum of deep blues and purples. Yet the glare remains a threat. You observe the consistency of this facial structure across the group, a steady guardian against the encroaching frost. This structural optimization allowed for the settlement of vast territories that would have been impenetrable. Having established the biological shield, we must now examine the specific structural anatomy that defines this unique gaze. The evolution of the epicanthic fold serves as a biological response to the environment, but to understand its function, you must first examine its mechanical architecture. You shift your focus from the prehistoric tundra to the biological present, observing the eye not as an abstract feature, but as a complex topographical map. The sterile, sharp clarity of a medical illustration defines this perspective. There is no guesswork here. There is only the precision of the palpebral fissure. This fissure, the transverse opening between the upper and lower eyelids, serves as the primary aperture for light. In Asian ocular anatomy, the measurements reveal a distinct structural narrowing. This reduced vertical height of the fissure is not merely aesthetic, it is a calculated limitation of exposure. You observe the way the upper lid sits, often characterized by a lack of the superior palpebral fold. In Western anatomical models, this fold, commonly referred to as the double eyelid crease, is formed by the attachment of the levatab pebrae superioris muscle to the skin of the eyelid. In the monolid structure, this attachment is often absent or situated lower, resulting in a smooth, uninterrupted surface from the brow to the lash line. This absence of a crease creates a different mechanical tension across the eyelid surface. The fullness of the upper lid is further dictated by the distribution of orbital fat. You trace the protrusion of the preseptal and retroorbicularis oculiity fat pads, which are frequently more voluminous in Asian eyes. This padding contributes to a thicker, puffier appearance, providing an extra layer of insulation and protection for the globe of the eye. The weight of this fat pushes the eyelid skin downward, which directly influences the orientation of the eyelashes. Unlike the upward curving lashes found in other populations, the lashes here appear straighter and point downward, often partially obscuring the superior margin of the palpebral fissure. The scent of a clinical workspace ozonated air and the faint chemical trace of disinfectant accompanies this close-up inspection of the ocular region. You see the technical reality of the skin's tension, the way the tissue resists the pull of the levator muscle, creating a surface that is both resilient and streamlined. This structural arrangement is a masterclass in biomechanical efficiency, designed to regulate the intake of light and protect the delicate cornea from external debris. The downward pointing lashes act as a primary filter, catching dust and particulates before they can reach the surface of the eye. Every millimeter of fat and every degree of lash tilt serves as a logistical safeguard for the visual system. You note how the skin's texture remains taut, the absence of the superior fold, preventing the characteristic sagging often seen in thinner, creased lids over time. This is not a deficiency, but a different architectural solution to the problem of environmental exposure. The meticulous layering of the orbicularis oculi muscle and the fat deposits beneath it create a thermal barrier, a biological vestige of the need to retain heat in the orbital cavity. Each component, from the narrow fissure to the straight lashes, functions in a cohesive, synchronized manner to maintain the integrity of the eye. As you conclude this structural survey, the focus begins to shift from the individual anatomical drawing to the broader distribution of these traits. While these traits are often associated with one region, the genetic map of the epicanthic fold is surprisingly global. The biological reality of the monolid is a testament to the body's ability to adapt its own structure to meet the demands of history and geography. Understanding the architecture of the monolid requires acknowledging that there is no singular, correct form, only variations in mechanical efficiency. When we examine the biological present, we see that what was once a survival mechanism in the harsh climates of the North has become a defining characteristic of beauty and identity. The technical reality remains. The narrower palpebral fissure and the presence of orbital fat provide a unique defense against the elements. This is a story of persistence. As we look at the global map, we find these features popping up in unexpected populations, from the indigenous groups of the Americas to certain South African tribes. The epicanthic fold is not a wall, but a bridge across human history, proving that our bodies carry the record of everywhere we have ever been. We are, in every sense, a collection of architectural choices made by our ancestors. The study of the eye is the study of our shared journey through time and space. While these traits are often associated with one region, the genetic map of the epicanthic fold is surprisingly global. The anatomical structures analyzed in the previous chapter, while precisely defined in East Asian populations, do not exist in isolation within a single geographic or ethnic silo. You are now observing a data-driven visualization of the human genome where the vast, shifting colors of a global map illustrate the kinetic energy of human movement across millennia. This cartography of migration reveals that the epicanthic fold, the distinctive superior integumentary layer, is not an exclusive biological marker, but a shared human trait distributed across diverse continents. As the map flows from the steppes of Central Asia into the reaches of the North, you note the presence of these folds among the indigenous populations of the Americas. This is a direct consequence of phenotypic persistence following the crossing of the Bering Land Bridge. The genetic signal does not terminate at the edge of the Pacific, it is carried through the Arctic and into the vast boreal forests and southern plains, where the fold remains a functional element of the ocular structure in numerous First Nations and South American indigenous groups. We see a legacy that spans thousands of miles and tens of thousands of years, proving that our features are the ultimate travelers through time. Moving the perspective to the west, the data disrupts the common archaeological assumption of rigid silos. You find that epicanthic folds actually occur within European populations, albeit at a significantly lower frequency. In these regions, the trait is often manifested in infancy or survives as an inherited anatomical variation in adults, frequently found in Scandinavian and some Eastern European lineages. The mechanism is identical, the protarsal fat and the tension of the medial canthus, but the frequency of the fold is considerably lower in non-Asian populations compared to the ubiquitous presence in East Asian demographics. The statistical shift is stark. While it may be a standard feature in one region, in the West, it becomes a distinct anatomical outlier, a remnant of ancient genetic drift or independent adaptation to cold and high UV environments. It is a biological whisper of our shared origins, appearing in the fjords and the plains of Europe as a rare but undeniable physical link to our collective past. The diversity of the human face is far more complex than any map can draw. As the historical survey continues into South Asia and the African continent, the technical reality of human diversity becomes even more apparent. You observe the epicanthic fold appearing in the San people of southern Africa and among various South Asian groups where environmental pressures may have selected for similar protective ocular features. It is a biological response to the environment, a structural mitigation against debris and intensity. However, the observer must exercise rigorous precision. The persistent idea that all Asian eyes look the same is a demonstrable misconception. When you adjust the lens to focus on the populations of China, Japan, Korea, and Southeast Asia, the data reveals significant diversity. There is no singular Asian eye. Instead, there is a spectrum of eyelid heights, degrees of fold coverage, and variation in the nasolacrimal duct's exposure. Some individuals possess a complete fold that obscures the caruncle, while others exhibit a minimal ridge. The thickness of the subcutaneous fat and the specific insertion point varies from one lineage to the next, creating a complex tapestry that defies simplistic categorization. This genetic map is not merely a record of where people have gone, but a catalogue of how we have adapted. You see the movement of alleles across the Silk Road and the migration routes of the prehistoric world, where the exchange of genetic material ensured that these ocular traits would surface in the most unexpected latitudes. Every migration event has left a signature in the orbital anatomy of modern humans. The scent of salt air and the dry, stinging grit of the desert wind are historical constants for these migrating groups. The eye, in its mechanical wisdom, adapted to protect the sensitive cornea. The epicanthic fold is thus a tool of endurance, a specialized piece of biological equipment used by various ancestors across the globe to navigate harsh landscapes. It is a testament to the fact that we are a single, highly mobile species sharing a toolkit of physical traits. Yet, the evidence shifts from the external to the systemic. Beyond ancestral heritage, the presence of the fold can sometimes serve as a silent messenger for internal health. The focus of the investigation shifts from the broad strokes of human migration to the granular precision of the clinical examination room. In this sterile environment, the epicanthic fold undergoes a transformation in status. It is no longer merely an ethnic marker or an evolutionary adaptation to climate, but a biological sentinel. You observe the clinician as they approach the patient, the silence of the room punctuated only by the rhythmic ticking of a diagnostic clock, a metronomic pulse that underscores the high-stakes nature of genetic screening. In the context of medical dysmorphology, the presence of these skin folds is catalogued with the same detachment as a heart murmur or a laboratory blood panel. While the epicanthic fold is a normal variant in many populations, its manifestation in certain diagnostic clusters serves as a primary visual indicator for chromosomal abnormalities, most notably trisomy 21 or Down syndrome. Here, the fold is often accompanied by an upward slant of the palpebral fissures and brush-filled spots on the iris, forming a constellation of signs that the medical professional must interpret with rigorous accuracy. The skin, stretched over the medial canthus, becomes a surface upon which the underlying genetic architecture is written. As the diagnostic clock continues its steady cadence, the clinical gaze expands to include environmental and metabolic factors that influence fetal development. You witness the recording of data points where the fold serves as a hallmark of fetal alcohol syndrome. In these cases, the epicanthic fold often appears in conjunction with a smooth philtrum and a thin upper lip, physical markers of neurodevelopmental disruption occurring in utero. The fold is not a singular phenomenon, but a component of a wider phenotypic pattern. Similarly, in the diagnosis of Turner syndrome, a condition characterized by the partial or complete absence of an X chromosome in females, the presence of epicanthic folds is a documented clinical finding, often noted alongside a webbed neck and low-set ears. The technical vocabulary of the clinic demands that these observations be stripped of subjective interpretation. The fold is a physical measurement, a deviation from the population mean that suggests a deeper disruption in the biological code. The clinician's pen moves across the chart, marking the presence of the fold as a positive finding within the diagnostic protocol. Beyond chromosomal and developmental syndromes, the epicanthic fold acts as a sentinel for specific metabolic disorders. You observe the protocol for screening phenylketonuria, or PKU, an inborn error of metabolism where the body cannot properly break down the amino acid phenylalanine. While PKU is primarily managed through dietary restriction, the physical manifestation of the fold in certain patients provides an early visible clue to the metabolic imbalance that, if left untreated, leads to severe intellectual disability. The stakes of this visual analysis are high. The fold is the surface-level signal of a deep-seated chemical failure. This diagnostic significance extends further into the realm of peroxisomal disorders. In the case of Zellweger syndrome, a rare and fatal congenital disorder characterized by the reduction or absence of functional peroxisomes in the cells. The epicanthic fold is established as a consistent diagnostic sign. In these infants, the fold appears alongside a flattened facial profile and a large anterior fontanelle, representing a total systemic collapse of cellular detoxification. The air in the clinic is sterile, smelling of isopropyl alcohol and latex, a sharp contrast to the gravity of the genetic data being processed. The utility of the fold as a sentinel relies on the clinician's ability to differentiate between benign hereditary traits and pathological indicators. In a population where the fold is statistically common, its presence in a neonate may carry no diagnostic weight. However, when it appears outside of these ancestral contexts, or in tandem with other dysmorphic features, it triggers an immediate escalation in clinical scrutiny. The fold is, in essence, a data point in a complex algorithm of human health. It serves as a visual proxy for the unseen, the arrangement of chromosomes, the sequence of DNA, and the efficiency of cellular metabolism. The process of observation is methodical. The clinician uses a pen light to check the pupillary response, the beam of light momentarily illuminating the fine bridge of skin that covers the inner corner of the eye. This is the intersection of aesthetics and pathology, where a simple fold of the eyelid becomes a critical variable in the survival and management of the patient. The diagnostic clock ticks onward, marking the passage of time as the clinical picture comes into focus. To understand the fold, we must also define what it is not, distinguishing it from other common eyelid conditions. The clinical identification of the epicanthic fold as a biological marker mandates a rigorous comparative analysis to prevent diagnostic conflation with unrelated eyelid pathologies. To understand the structural integrity of the ocular region, you must first distinguish the fold from ptosis. While the epicanthic fold is a vertical or semilunar skin flank extending from the upper eyelid toward the inner canthus, ptosis represents an entirely different mechanical failure. Specifically, ptosis is characterized by the drooping of the upper eyelid itself, often caused by a dysfunction of the levator palpebrae superiors muscle or its nerve. You observe the physical reality of this condition as the lid margin sinks lower than the anatomical standard, occasionally obstructing the superior visual field. Unlike the epicanthic fold, which is a structural feature of the skin, ptosis is a functional deficiency. When you palpate the orbital area, you note the tactile sensation of skin elasticity and tension. In ptosis, this tension is absent, replaced by a flaccidity where the eyelid fails to retract under neural command. The distinction is critical. In one is a morphological variation, the other a muscular or neurological impairment. The distinction is critical. Entry, when Ucity was unical excellences. Progressing from muscular dysfunction to integumentary distribution, you must differentiate the fold from the phenomenon of hooded eyes. This condition is frequently confused with the epicanthic fold in non-clinical discourse, yet the mechanism is distinct. Hooded eyes occur when an excess of skin, often the result of the brow bone structure or age-related dermatochalasis, droops over the eyelid crease, effectively concealing the mobile lid. You note the specific topography of this arrangement. The skin hangs as a fleshy canopy, whereas the epicanthic fold is a taut bridge covering the medial canthus. The tension you feel between your fingertips when examining a hooded eye is one of excess volume, rather than the specific directional pull of the epicanthal transition. Where the fold is characterized by its internal placement of the tear duct, the hooded lid is a global descent of the supraorbital skin. Both conditions alter the visible surface area of the eye, but their developmental and anatomical origins occupy different strata of human physiology. This structural analysis inevitably collides with the persistent myths regarding ocular dimensions across global populations. A pervasive and scientifically inaccurate stereotype suggests that Asian eyes are universally smaller than those of other ethnic groups. You examine the metric data and find this to be a fundamental misinterpretation of visual occlusion versus orbital size. The presence of an epicanthic fold or a low-set tarsal crease may create an optical illusion of reduced width or height, yet the underlying globe, the eyeball itself, maintains a consistent volume. Eye size is a biological variation found throughout the human species. It is not a universal ethnic trait governed by ancestry. You observe individuals with prominent epicanthic folds who possess larger corneal diameters than their Western counterparts, dismantling the notion of a standardized smallness. The anatomical reality reveals a profound diversity in the palpebral fissure, the opening between the eyelids, that transcends geographic origin. This variation is a testament to the distribution of soft tissue and skeletal architecture rather than a fixed racial marker. In the laboratory or clinic, the precision of these distinctions serves as the primary defense against oversimplification. By documenting the exact position of the skin fold, the strength of the levator muscle, and the depth of the orbital socket, you provide a clear map of human ocular diversity. The tactile resistance of the skin and the structural depth of the eye socket are the raw data points of this survey. You move your fingers across the zygomatic bone, noting how the skin stretches differently when anchored by a fold versus the loose redundancy of a hooded lid. This meticulous classification strips away the subjective baggage of difference and replaces it with the objective reality of structural mechanics. The eye is not a static symbol, but a complex assembly of cartilage, muscle, and dermis, each subject to its own unique tension and placement. With the anatomy defined, we turn to the cultural mirror, where these features are assigned value and beauty. The biological variants of the epicanthic fold and the biomechanics of the levator palpebrae superioris muscle provide the structural foundation for the Asian eye. Yet these physical realities are filtered through a complex prism of regional aesthetics. You observe this transition from the clinical to the cultural within the silent confines of a private dressing room. The soft glow of a vanity mirror casts an amber luminescence across a polished surface, illuminating the tools of self-presentation. Here, the eye ceases to be merely an organ of sight and becomes a site of cultural semiotics. In this space, the diversity of eye shapes across all Asian populations is not a matter of taxonomy, but of identity and inherited grace. This diversity is vast, encompassing a spectrum of fold depths and orbital heights that defy any singular categorization. Yet distinct regional preferences have emerged over centuries of social development. Each curve of the lid, each subtle tension of the skin, tells a story of lineage that predates the modern gaze. We look into the glass and see not just ourselves, but the weight of generations looking back. As you adjust the angle of the mirror, the play of light highlights the subtle contour of a monolid or single-folded eyelid. Or single-folded eyelid. In several East Asian cultural contexts, particularly within various historical periods in China, Korea, and Japan, this specific configuration, a smooth transition from the brow to the lash line without a secondary crease, is traditionally considered highly desirable. It is an aesthetic characterized by linearity and refinement. You see this reflected in the classical inkwash portraits of the Tang dynasty, where the eyes are rendered as elegant, sweeping strokes, emphasizing a gaze that is perceived as composed and intellectually focused. The absence of a supratarsal crease is not viewed as an absence of form, but as a specific structural elegance that prioritizes the continuity of the skin's surface. Every movement of the lid is measured, a mechanical display of the underlying connective tissues working in seamless unison. This is the beauty of the unbroken line, a visual silence that speaks of restraint and poise. However, shift your gaze toward the maritime trade routes and tropical climates of Southeast Asia, and the aesthetic mirror reflects a different priority. In these regions, a double eyelid, characterized by a visible crease that creates a distinct shelf above the lash line, is frequently the preferred standard. This preference is rooted in the visual effect of the double fold, which serves to make the eye appear structurally larger and the orbital opening more pronounced. From a technical standpoint, the presence of the crease increases the visible surface area of the eye when open. A feature that you observe is often perceived as more expressive in specific cultural contexts. The depth of the crease allows for a more dramatic interplay of light and shadow, which is often interpreted as a sign of openness or emotional transparency. The physical mechanics of the double eyelid allow for a greater degree of animation in the upper face, a trait valued in communal social structures where nonverbal communication is paramount. This regional divergence is not a monolith. It is a stratification of taste shaped by climate, migration, and long-standing social hierarchies. You notice the meticulous nature of the visual language, how a single millimeter of skin fold can signal regional lineage or social standing. The metallic tang of a bronze mirror or the cool touch of a jade applicator serves as a reminder that the pursuit of these ideals is an ancient labor. While some populations naturally exhibit the double eyelid, others possess the single fold due to the concentration of pretarsal fat pads. Neither is a biological error. They are simply variations in the subcutaneous architecture of the face. In the quiet of the vanity, the dust motes dance in the lamp's warmth, settling on scripts that detail the changing tides of beauty. You see the transition toward an era of more permanent modification. The weight of societal expectation begins to exert a physical force on the anatomy itself. This cultural preference eventually led to the birth of modern aesthetic surgery in the late 19th century. The year is 1896. In the burgeoning medical landscape of Meiji-era Japan, the intersection of traditional aesthetics and Western anatomical study produces a singular point of clinical evolution. You observe a workspace defined by the rigorous order of late 19th century medicine: glass vials of carbolic acid for sterilization, a set of high-carbon steel scalpels, and the steady, methodical movement of a focused practitioner. The air in the room carries the sharp clinical scent of antiseptic, a stark contrast to the humid, earthy atmosphere of the streets outside. This is the clinic of Dr. Koto Mikamo, a surgeon whose work is about to codify a new branch of aesthetic medicine. Mikamo is refining a technique that will bridge the gap between inherited anatomy and a newly emerging desire for surgical intervention. You hear the crisp sound of parchment as the surgeon records his findings, the quill scratching rhythmic precise lines that document a procedure never before standardized in the medical canon. Technically classified as blepharoplasty, the procedure Mikamo is pioneering addresses the anatomical structure of the eyelid. In many East Asian populations, the levator aponeurosis, the muscle responsible for lifting the eyelid, does not always attach to the skin in a way that creates a supratarsal fold. The result is what is colloquially known as a monolid. Mikamo's innovation is the intentional, surgical creation of a permanent crease in the eyelid, effectively altering the physical architecture of the facial features. He is not merely treating a pathology or repairing a trauma. He is performing what will become recognized as the first documented instances of double eyelid surgery for aesthetic purposes. The mechanical process involves minute incisions and the strategic placement of sutures to tether the skin to the underlying muscle, ensuring that when the eye opens, the skin folds back upon itself in a predictable, linear fashion. You watch as Mikamo examines a patient, his hands steady and gloved in early thin rubber. The tools of his trade are delicate, designed for ophthalmic precision. The metal of the forceps is cold and brushed, reflecting the dim gaslight of the late 19th century surgery. The patient remains still, the procedure often performed under local anesthesia, perhaps a cocaine derivative, which numbs the delicate tissue while allowing the patient to remain conscious of the pressure. Every movement of the scalpel is a calculated risk against the vascular density of the eyelid. One misplaced stroke could result in significant hematoma or nerve damage. However, Mikamo's notes reflect a high degree of success, detailing the exact measurements required to achieve symmetry between the left and right ocular orbits. He records the depth of the tarsal plate and the tensile strength of the thread used to create the crease, treating the human face with the same structural scrutiny an engineer might apply to a bridge. This breakthrough marks the definitive beginning of modern Asian aesthetic surgery. Prior to Mikamo, modifications of the face were largely the domain of cosmetics, powders, paints, and temporary adhesives that could be washed away at the end of the day. Mikamo's work moves the needle into the realm of permanence. The result of his blepharoplasty is a fundamental shift in the subject's visual expressiveness. By creating a double eyelid, the surgeon enlarges the perceived aperture of the eye, a change that aligns with the contemporary Meiji-era fascination with integrating Western scientific and social markers into Japanese life. You observe the meticulous care with which he stitches the fine silk thread, the knots tied with a jeweler's precision to minimize scarring. The physiological gravity of the procedure is immense. It is an irreversible reconfiguration of the self, etched into the flesh with a blade. The medical community of 1896 begins to take note of these developments as Mikamo publishes his results. The data is empirical and cold. Healing times, infection rates, and the longevity of the fold over several months of follow-up observation. There is no sentimentality in his records, only the objective measurement of tissue response and the stabilization of the surgical site. The sensory experience of the recovery ward is one of silence and the smell of clean linen. Patients rest with damp cloths over their eyes to reduce the inevitable swelling and the bruised purplish discoloration of the delicate skin. As the inflammation subsides, the new crease emerges, a sharp, deliberate line where once there was a smooth expanse of skin. As the 19th century draws to a close, the implications of Mikamo's innovation extend far beyond his small clinic. Mikamo's legacy evolved into two distinct surgical paths, the invasive and the subtle. The evolution of the supratarsal fold from a documented rarity in the late 19th century to a standardized medical procedure required the development of a highly specific surgical architecture. This evolution culminates in the modern incisional protocol, a mechanical intervention designed to permanently alter the physiological topography of the periocular region. Unlike the temporary cosmetic tapes of the past, this procedure is an exercise in structural engineering. You observe the preparation of the surgical field, the environment is sterile, and the air carries the sharp clinical scent of isopropyl alcohol and povidone iodine. As the instrumentation is arranged on the tray, the cold metallic clink of surgical steel provides a rhythmic acoustic backdrop to the deliberate silence of the operating room. This sound marks the transition from the theoretical to the physical, signaling the commencement of an irreversible anatomical modification. The metallic clink is the first step toward a permanent change, and the incisional method is the primary solution for patients presenting with significant skin laxity or a high volume of orbital fat, conditions that preclude less invasive techniques. The protocol begins with a precise marking of the intended crease line, typically 6 to 8 millimeters above the lash line. This measurement must be exact, as it determines the symmetry and height of the final fold. Once anesthesia has stabilized the blood vessels, the surgeon employs a scalpel to execute a physical cut along the marked line. This incision is not merely superficial. It serves as the gateway to the underlying structures of the eyelid. The resistance of the dermis against the blade is minimal, yet the consequence of the cut is absolute. You see the separation of the skin edges, revealing the hidden layers of muscle, and the distinct yellow hue of the orbital septum beneath. Following the primary incision, the mechanical manipulation of soft tissue becomes more intensive. In patients with pronounced puffiness or drooping, the protocol mandates the removal of excess skin. This is a subtractive process calculated to remove specific millimetric strips of tissue specialized for the eyelid's complex mobility. Simultaneously, the surgeon addresses the deeper fatty deposits. Using fine forceps and cautery tools, portions of the preponeurotic orbital fat are identified and excised. This fat, which provides the eyelid with its rounded volume, is systematically reduced to allow for a flatter, more defined surface area where the new fold will reside. The smell of thermal cauterization, a byproduct of sealing small blood vessels, permeates the space. It is a sensory indicator of the heat used to prevent hemorrhage within the delicate ocular tissue. The removal is permanent and irreversible. With the obstructive tissue removed, the protocol enters its most critical phase, the creation of the permanent adhesion. In a natural double eyelid, fibrous attachments connect the levator muscle to the underside of the skin. In the incisional procedure, these connections are artificially engineered. The surgeon uses non-absorbable sutures to anchor the lower skin flap directly to the levator aponeurosis. This mechanical tethering ensures that when the levator muscle contracts to open the eye, it pulls the skin inward, creating the characteristic fold of the supratarsal crease. The tension must be calibrated with mathematical precision. If too tight, the eye may fail to close completely, The edges of the skin are then brought together with microscopic sutures, often finer than a human hair. Each stitch is a testament to the standardization of modern practice. For those seeking a less permanent or invasive change, the non-incisional method offers a different mechanical solution. The evolution of modern blepharoplasty has moved toward the minimization of trauma, prioritizing structural permanence with the least possible disruption to the biological casing of the ocular region. You observe the transition from the traditional incisional protocol to the refined mechanics of the non-incisional or buried suture technique. This procedure is defined not by the scalpel's edge, but by the calculated application of tension. The patient is prepped in a clinical environment where the air carries the faint, sterile scent of isopropyl alcohol and the ozone of high-frequency medical equipment. Unlike the previous era of surgery, there is no large-scale excision of tissue. The biological integrity of the eyelid remains largely intact. The surgeon identifies specific points on the upper tarsal plate, marking them with surgical ink. These coordinates serve as the entry and exit points for the mechanical reconstruction. You watch as a series of micropunctures are made in the skin, often no larger than the diameter of the needle itself. These tiny perforations act as conduits for the corrective material, bypassing the need for a continuous incision across the lid. At the core of this methodology is the interaction between the skin and the levateus aponeurosis, the muscle responsible for lifting the eyelid. In a naturally occurring double eyelid, a biological connection exists between these layers. In the absence of one, the non-incisional technique creates a synthetic bridge. The surgeon introduces a fine, non-absorbable monofilament suture through the micropunctures. This thread, often made of nylon or polypropylene, is woven in a continuous or interrupted pattern, threading through the dermis and securing itself to the underlying muscle or the tarsal plate. The mechanics are simple yet exacting. By binding these two layers together, the suture forces the skin to fold inward when the levator muscle contracts to open the eye. You witnessed a moment of calibration as the surgeon adjusts the loop. You perceive the delicate tension of a fine thread being pulled taut, a minute resistance that signifies the creation of a new structural anchor. This tension must be precise. Too loose, and the crease will fade. Too tight, and the lid will suffer from unnatural eversion. One of the primary advantages of this technical approach is what is absent from the surgical field. There is no removal of suborbicularis's oculi fat, nor is there any excision of excess skin. The internal landscape of the eyelid remains crowded with its original biological components, now merely rearranged by the pressure of the buried thread. Because the vascular system of the lid is largely undisturbed, the inflammatory response is significantly muted. The heavy bruising and prolonged edema associated with incisional methods are replaced by manageable swelling. This leads to a distinct clinical outcome, a shorter recovery period. In a modern economy where time is a commodity, the ability for a patient to return to social visibility within a matter of days rather than weeks is a significant driver of this technique's popularity. The patient experiences a much faster return to normalcy without the heavy aesthetic burden of traditional surgery. Furthermore, the lack of a continuous incision line addresses the aesthetic requirement for invisibility. In the absence of a scar, the surgical intervention becomes difficult to detect with the naked eye. The punctures heal rapidly, leaving behind no fibrous scar tissue. The buried nature of the suture means the mechanical agent of change remains hidden, functioning as a permanent internal scaffold. You observe the final knot being tied and the ends trimmed with microscopic scissors, the suture ends disappearing into the dermis. The eye is then tested. The patient is asked to open and close their lids. With every upward gaze, the tension of the thread pulls the skin into a crisp, predictable fold. However, the durability of this method is entirely dependent on the integrity of the suture knot. Over years, the constant mechanical stress of blinking, thousands of times per day, can cause the suture to cheese wire through the soft tissue. This risk is the trade-off for a scarless, rapid procedure. Beyond the operating table, the daily ritual of transformation continues through the art of illusion. The mechanical tension of surgical sutures represents a permanent structural alteration, but for many, The modification of the supraorbital area does not begin in the operating theatre. It begins at the vanity table through the application of temporary polymers and adhesives. You observe the daily ritual of orbital reconfiguration, a process dictated by the physics of surface tension. In the absence of a natural attachment to the dermis, the contemporary individual utilizes Yelled tape, a medical-grade polyolefin strip. You take a pair of fine-tipped tweezers and peel a crescent-shaped sliver of this film from its backing. As you apply it to the pre-sanitized skin, you feel the tacky, adhesive pull of the tape against the delicate epithelium. This microtension forces the skin to fold onto itself when the eye is opened, mimicking a tarsal plate attachment and creating a temporary artificial crease that lasts only as long as the adhesive maintains its bond. Technological alternatives involve the use of halide glue, an aqueous-based liquid adhesive. You apply a thin line of the white viscous fluid along the desired crease line using a small plastic applicator. The cooling sensation of the liquid quickly gives way to a tightening effect as the water evaporates, leaving behind a flexible, transparent film. And you use the prong to push the skin upward, bonding the lower portion of the lid to the upper portion. This creates a temporary double eyelid effect by physically gluing the skin into a recessed fold. The skin feels taut, a constant sensory reminder of the artificial topography being maintained against the natural elasticity of the tissue. Unlike surgery, these methods are subject to the environment. Perspiration and oils gradually weaken the polymer chains, eventually resulting in the collapse of the fold and the restoration of the original profile. Beyond these structural adhesives, the manipulation of the eye's perceived dimension relies heavily on the application of pigment. You participate in the systematic layering of matte and shimmer powders and exercise in optical physics. The goal is the creation of depth, a visual deception meant to suggest a three-dimensional recession where the anatomy is relatively flat. You map the eye's surface, applying darker, carbon-based pigments specifically to the outer corners. This concentration of darker values at the lateral canthus serves to recede the area visually, effectively lengthening the perceived horizontal axis and altering the overall shape. The tactile experience is one of precision. The soft bristles of the blending brush deposit microscopic particles of mica, filling the fine lines of the skin and creating a gradient that fools the observer's eye into seeing a deeper orbital socket. This labor of cosmetic application functions as a non-invasive bridge between biology and personal preference. Every layer of pigment and every strip of adhesive serves as a temporary modification, allowing for a daily renegotiation of the facial landscape. These methods require a high degree of manual dexterity, as the placement of a crease just a millimeter too high or low can disrupt the facial symmetry or cause physical discomfort. You see the reflection in the glass, a face transformed through the calculated use of materials and light, a testament to the human desire to master the canvas of the self. From evolutionary shield to modern aesthetic choice, the story of the eye remains a testament to human diversity.